Thank you, Chris. Um, this is a topic that is really very close to my heart. I'm very fond of this implant, and I'd like to share our experience. So historically, we all started with hinges, the single-axis hinges, several of them, and the first generation of rotating hinges was the Noyles and the Link, and these really gave pretty poor results. One of the earliest reported cases in literature was by Rand. These were mobile bearing but loaded entirely through the hinge mechanism, and a huge incidence of failures. Only 65% were success stories. So the first generation rotating hinges failed because they had suboptimal patellofemoral mechanics, inconsistent alignment, unreliable fixation, a very poor hinge assembly, and inadequate congruency of the mobile bearing. So the problems that we saw with those was that they loosen pretty easily. They had significant extensor mechanism ruptures, and we've already heard what a challenge it is to deal with these. Patellar issues were quite profound. They broke oftentimes, and it was really a nightmare to try and salvage this. So the modern rotating hinges are a completely new ball game. There are deeper trochlear grooves. They are mobile bearing with polished cobalt chromium, metaphysical augments, and better stem fixations. And again, going back historically in 91, Finn reported on his cases 44 knees, and again you see that there's a significant 20% of failure rates in these. So what are the indications for rotating hinges? Some part of this was discussed in the case discussion. When you have loss of the collateral ligaments, huge bone loss is compromised of the collaterals, extremely large flexion gaps, periprosthetic supracondylar fractures, tumors, neuromuscular recurvatum, severe bone loss, it may be on account of either fracture, osteolysis, tumors, and last but not least, weakness or deficiency of the extensor mechanism. So what is an ideal hinge? One that is condylar loading, minimal bone removal, maximum jump height, resistance to patellar subluxation, something that can take an augment stem, and it should be seamlessly possible to do this from a constrained or a primary options, and should have multiple sizes. So we've had pretty extensive experience with the rotating hinge next-gen system, where 95% of the compression forces go through the condyles, making this really a condylar loading implant. And it gives you almost 4 centimeters of a jump height, which is pretty phenomenal. When you look at the comparison with the existing available hinges, you find that the width and the depth measurements are very favorable in terms of dissecting very little bone and yet having a very pronounced jump height. The most important thing from my perspective is that it's very easy to convert from a primary in the situation that you end up sometimes if you have gross instability, you can actually move over to these pretty seamlessly. It can take in an augment, and it really needs a huge imbalance to dislocate this once it's done properly and you've set the rotation. And it allows you to balance and align your extensor mechanism really well. I must put a point here that certainly in this part of the world, some of the primaries that we get are more challenging than the revision situations. So there is a case for using a hinge in some of these really horrifically deformed primary knees, disorganized knees, periarticular fractures, failed osteosynthesis, and sometimes in primary situations where there are implants that are failing. Here is a typical situation. This is not a neuropathic joint. We did all the studies. This is actually a rheumatoid, and we had to do this rotating hinge in this very severely disabled patient. This is yet another example of a patient where we had to do a revision done elsewhere, came to us with a disorganized knee, fracture of the implant, periprosthetic fracture, and we had to salvage this by using a rotating hinge. This is a patient who had a failed osteosynthesis, non-united femur, femoral condylar fracture, had a dislocated patella, and we did a CT scan, and really the only salvage mechanism that was available to us was to use a rotating hinge. So we've used this in a spectrum of different indications, and this is the patient out at almost 6 years, and this patient has really done exceedingly well. A comminuted supracondylar fracture where we used a distal femoral replacement, again using the philosophy of a rotating hinge, and we were able to align this knee, made the patient walk within 24 hours of the index surgery. In some revision situations, this patient had had multiple revisions, had pronounced bone loss in the distal femur proximal tibia. And again, this was salvaged using a rotating hinge and an offset stem with a metaphyseal cone. This is a very interesting patient. She'd had almost 3 previous surgeries, 2 previous revisions, and had needed a revision on the contralateral side. This was one of the indigenous knees which was put. We had really no way of finding out what it was. We had to use a high-speed burr to cut and remove this, and we used a TM augment which we shaped to be able to fit into this large defect. She had a laterally dislocated patella which we had to realign, and this patient really did quite well until one day she fell down and disengaged her condyle. So obviously she exceeded the jump height of 40 millimeters. We had to go back into this knee again and realign it, increase the height, and she ended up with a stable construct. But what you do see here is that we have got the patella in a slightly lower position. We've had considerable experience of doing tumors, and this is a osteogenic sarcoma. And in this patient, at 1 year, we resected this, this was a chondrosarcoma which we resected, and we did a rotating hinge. These are her x-rays at 1 year. A giant cell tumor of the proximal tibia, again, which was resected. We used a TM cone, and what you can see, interestingly enough, is the formation of new bone, in spite of the fact that a large part of the metaphysis and diaphysis was unsupported. So it does stimulate osteogenesis in these situations. This was a giant cell tumor where we resected and did a RHK, and this was a large tumor which recurred and turned malignant. This is something that we've done just about a couple of weeks ago, and this patient is just been discharged. We had to do a segmental resection and distal femoral implant. So the polyethylene can disengage. LCCKs do disengage, as does RHK. And when that happens, you revise it to an RHK. The fundamental principle I like to highlight here is constraint alone does not guarantee stability. You have to align it and fix it well. So you need to use fundamentally the least constraint to get a stable implant, and non-linked options will solve the majority of soft tissue issues if your medial collateral is intact. And no constraint will help if issues like malalignment persist. So this is our experience, which we reported in 2012. We have now done almost about 284 of these procedures, and our survivorship at 10 years is 92%. Thank you for your attention.